Hi, everyone, and welcome to our March Fast Facts. And I'm really excited because by popular demand and request, a lot of attendees were interested in public health regulations. And so I'm very excited to go over this over the next hour with two amazing colleagues of mine, Jonathan Harwood, who is the Interim Bureau Chief of Long-Term Care, and Somi Nagaraj, who is our Unit Manager in our Office of Healthcare Regulation. For those who don't know me, I'm Aarti Barnes, Chief Medical Officer at IDPH. And before we dive in, just a little bit of housekeeping. You do get CME for this. The post-survey webinar will be up for about 7 days. You can also get a certificate of participation if CME does not apply to you. The no financial disclosures among the group of presenters and preparers today. And just a little bit more housekeeping. The live chat will be disabled. These sessions are recorded. The recording is usually available eventually online, but will be given to the attendees and of the webinar too. If you have a question, use the Q&A function that's at the bottom right of the screen. So over the next hour, we are not going to cover every single aspect of IDPH regulation, but we are going to focus and hone in on hospitals, ambulatory surgical care centers, and long-term care facilities, also commonly known as nursing homes, in that category of nursing homes. But we're not just going to go into the what, we're going to go into how, the how of the process of complaint investigations and what the implications are for something like an immediate jeopardy. Those who haven't ever encountered that term, maybe you're lucky, but the goal is you will never encounter that term, hopefully with a little better knowledge. And we're hoping clinicians have a better knowledge of the regulatory framework at the end of the session. So the challenge is not a lot of us have great nascent education on facility level regulation in our training, right? We learn about our own individual licensure, but facility level regulation and compliance is critical. That and frontline healthcare workers, regardless of whether you're a decision maker or not, are the ones who really hold regulatory compliance in their hands, and a lot hinges on them. So not only is it important to understand that, it really avoids legal risks, improves patient care. And I will show you there's a shocking amount of information that's available publicly on your facility that's important to know. And so your reputation really hinges on that as someone who works at a certain facility. And as Somi and Jonathan will go into in a little bit, the loss of a potential revocation of license or potential immediate jeopardy where such egregious offenses occur that operations have to be halted is pretty staggering. So I'm asking each of you, do you know currently, if you work at a healthcare facility, how strong, how committed is your leadership? How comprehensive are your policies? How much education have you received on this so far? What's the risk assessment like? And monitoring, like, how does your day-to-day record keeping and documentation feed in to the information needed for regulatory compliance at the state level? And, how facile is your program? Who responds? So often you may have, if you've encountered a survey, you've said, well, we got cited for this code violation. What's a code? Do you mean we violated the law? And so here's a little bit of conceptual difference for people who don't live in this space. The law is, whether it's federal, then it's by Congress, it's really established by the General Assembly. It gives you a very broad policy and authority to act. The administrative code is the instruction manual on how the law gets implemented. So it works under the auspice, the code works under the auspice of the law. And to the right, you can see this is just a snapshot. This is not where really the scroll ends, but the link below will lead you to the code, the authorities in Illinois for the Illinois Department of Public Health. And it's Title 77. You can see water and sewage, mobile homes, pest controls. It's not always very intuitive what falls under our regulatory umbrella. And so I've just picked out a few, a small smattering, a selection of things that might be of relevance and importance for clinicians to know. healthcare facilities and services, we regulate. And Somi and Jonathan are going to really unpack that in greater detail over the next hour. But of note, we also provide designations. We designate stroke centers, trauma centers, birthing hospitals, transplant centers. And even, while all this occurs, it doesn't all occur within one umbrella within IDPH itself. So our Office of Healthcare Regulation oversees healthcare facilities. Our Bureau of Preparedness and Response oversees emergency medical personnel. We designate emergency systems for EMS systems for the state of Illinois. Our Bureau of Lab does lab compliance inspections. Our Office of Women's Health does school-based health centers. We oversee them. And our environmental health team oversees food safety. So we are the FDA delegate. So if there's contaminated food product on the shelf, we come to us to really try to address that and get those off the shelves. And interestingly, if you have a patient who had an adverse reaction at a body art and tanning facility, we oversee that too. You have recourse at IDPH. You don't if it's a med spa, but you do if it's a body art and tanning facility. And interestingly, we also certify several health professions, as well as professions that are adjacent to the health needs for the state of Illinois, including asbestos-led personnel, hearing and vision technicians. And we facilitate Medicare certification for portable X-ray services. So again, this is not an exclusive list. This is just to give you a sense of how intricate our regulatory framework really is at IDPH. And one thing I'm really excited and proud of is most recently we have started certifying community health workers, and it's a really wonderful program. We know how evidence-based it is to have more community health workers out there in our field. So this is where the nuance gets a little tricky. What we don't regulate. So we don't regulate urgent cares, but we do regulate freestanding emergency rooms. So it gets confusing for clinicians. We got a call a few weeks ago. A physician was very disturbed by the quality of care being received or provided at this urgent care, and we had no recourse. Ambulatory clinics, we in general don't regulate them, but with the exception of HRSA designated rural healthcare centers and birthing centers. But just because we don't doesn't mean no one else does. So substance use disorder facilities, sorry, I missed the word disorder there, which will be amended in the final slide deck, is really overseen by our Department of Human Resources. And while ambulatory clinics in general and urgent cares don't have a specific regulatory code under DPH, the licensed professional overseeing them is responsible. And so that will go through the DFPR's licensed healthcare professional. We do school-based centers, but we don't necessarily regulate schools. We do inform their vaccine requirements. And while we don't regulate municipal water, again, we get so many complaints of requests for investigation around that. It's again a tricky nuance. There's the Illinois Environmental Protection Agency. One thing that is important to note is that we do maintain a registry for unlicensed healthcare workers. And the title may get confusing if you don't read the fine print and you try to search for yourself in what you think is the Illinois Healthcare Worker Registry and your name doesn't show up. It's because this is only solely for unlicensed healthcare workers, like home health aides, CNAs. So we do maintain that. So hopefully this will give you a little bit of a sense of who's doing what within Illinois, within that regulatory framework. Now, beyond what I just mentioned, there's another mechanism that we oversee, not directly. This Healthcare Facilities and Services Review Board is under IDPH, but not fully always integrated, because I think there's an important separation that needs to occur there. But the Certificate of Need program is housed within this board, and it approves or disapproves any application for construction or expansion of healthcare facilities. So if you want to build a new cancer wing in your hospital, it has to go through HFSRB. And where do clinicians really find all this information? As I said, it's shocking how much information is publicly available. And if we went in live, I would ask for a show of hands of how many are aware of the Illinois Hospital Report Card. It seems like very few people are. And you can see just this open access information. Not only can you do a facility by facility comparison, you'll see there's a little button that says, it tells you about patient experience, quality at this facility, patient safety at this facility. But to your right, you can also see the costs and payer mix. So this was just, I pulled chest pain, cost of chest pain. Out of 6 facilities we pulled up, the range can go from maybe $47,000 to $18,000 to manage chest pain at this hospital. So I think if you're making decisions on behalf of your patients about what the cost implications are, please tap into these open resources. And HFSRB has another resource specific to certificate of need, and that will really give you more details on the certificate of need piece of it. It's just an example of that for any specific hospital. When it comes to nursing homes, the one last thing I'll close out with these last couple of things is that the federal CMS has a star rating. You can go look at how more stars, the better, less stars, the worse. But if you see that red line, the red sort of circle there, that means this facility was cited for abuse. And I think that when you're making decisions for your patients on quality of the nursing homes they choose, this is an important resource to tap in. If you're not aware of where else and you want further details on any specific violations, look at our quarterly report. Now, again, the law is not designed to be punitive. The goal of all laws is, I think, to be supportive in general, right? But more so with the adverse health event reporting law. So this has been in place for a couple of decades, but we are finally going to be able to launch a new platform that will allow hospitals to report any serious adverse events or never events. And this is based on the National Quality Forum. So as a clinician, you need to know all the 28 serious reportable events just to be, there are different categories of these. And below it is a link. If you can get the report on all these 28 events, 5 of them have just been added in the last year. So those are the ones the new ones I've mentioned. And so with that, again, you'll get an announcement, all the healthcare leaders specifically in the next week or so from DPH about the launch and rollout of this platform. And the goal is that we will be able to launch something in the next year. And with that, I'm really excited for that one. And I'm going to turn it over to Somi to tell you more about acute care hospitals and ambulatory surgical care centers.
Good afternoon. Thank you, Dr. Barnes and team, for giving me a chance. Good afternoon, everyone. My name is Somi, and I will be talking about the healthcare facilities and program surveillance in Illinois.
So sometimes you have to click like 1 or 2 times before it moves the slide.
I am trying to. Okay, there it goes. Thank you. First, I would like to say that this training is provided by the Illinois Department of Public Health, which is the Training and Technical Division. So this training is intended for healthcare facilities and programs training purposes only, and it's not intended for any official guidance. So for official policies or guidance, rules and regulations, we need to refer to CMS Quality and Safety Oversight, which is QSO policy memos, and the State Operations Manual for CMS or state laws and regulations. Okay. All right. So data disclosure, because I will be talking about a few data here as I speak furthermore. So the Center for Medicare and Medicare Services Quality Certification and Oversight Reports, which is QCOR. This page, due to system migrations, CMS has not been able to update the data since May 2022 because it's moving into iKeys. That's the new platform. So the data provided in this presentation is from Acute and Continuing Care Survey and Certification Dashboard from the iKeys. iKeys stands for Internet Quality Improvement and Evaluation System Portal. So data reported in this presentation ranges from January of 2023 to May of 2025. So what's happening is beginning from May 2021, the state agencies, state survey agencies, and CMS locations began to be phased transition into iKeys. So all the data that was originally in QCore is slowly moving into a different portal. So that's where I have obtained all the data here. Now, like how Dr. Barnes explained, due to time constraints, I'm not able to give you a detailed description of what healthcare facilities and programs do, but I'm just going to give you an overview. First of all, I would like to say that we healthcare facilities and programs, we do both state licensure surveys as well as federal surveys. So when you look at this picture, you can see that federal surveys are broadly classified into 5 categories: initial certification survey, recertification survey, complaint survey, complaint validation survey, and addition of services, especially for ESRD, dialysis survey, or adding any inpatient units for hospice survey. So when we say complaint survey and a complaint validation survey, there is a slight difference between the two. One is a complaint survey where we receive a complaint through a hotline and we get the information from various sources, and then we go and investigate that complaint. Complaint validation survey, for example, could be that hospital or that entity would have lost their deemed status. Now you may be wondering, what's deemed status stand for? Deemed status means any organization, any entity, let it be a hospital or OPT or a surgical center, that is being recognized or accredited by an accreditation organization like Joint Commission or DNV. Some organization has given the accreditation, then you call that as a deemed facility. Sometimes they lose the deemed status, then we go on a complaint validation survey. So I just showed you different kinds of federal surveys, but we do that for 14 different programs. So healthcare facilities and programs look into this 14 categories. What are those? Hospitals, home health agency, hospice, psychiatric rehabilitation, long-term acute care, children's hospital, outpatient physical therapy and speech pathology, psychiatric residential treatment facilities, which we call it as PRTF, comprehensive outpatient rehabilitation facilities, ambulatory surgical centers, which is ASCs, community mental health centers, which is CMHC, critical access hospitals, we call it as CA, end-stage renal dialysis centers, emergency preparedness survey, rural health center, and then under rural health center comes your FQHCs. You might have known about federally qualified healthcare clinics. Those come under the RHC, Rural Health Center. We used to do pregnancy termination facilities, but we don't anymore. And then we also do a special survey, which is nothing but your EMTALA, Emergency Medical Treatment and Labor Act surveys. Now, those that we discussed were all federal surveys. Now let's go into state licensure surveys. You can see here, state licensure surveys, we have 7 different categories, 7 different types. What are those? Initial licensure survey, which is some facilities just opening up, brand new. That's the time we go and do an initial licensure survey. We also do a resurvey, licensure resurvey. Usually it's done between 2 to 4 years. We do a complaint survey. Then we do change of ownership. Let's say some entity is changing their ownership, going home health agency or whichever entity may be. Then we go and do a change of ownership. Again, it is the discretion of the department. Springfield decides, the division chief, field operations chief, they decide if we have to go and do that type of a survey. Focused survey, we do it to determine the agency operations, and we also do focused survey to reinstate their license post suspension. Let's say, for example, a dialysis facility or another entity's license is suspended due to several reasons, maybe staffing, maybe practice, not being compliance. Then in order to put that back into compliance, we go and do a survey, to focused survey, call that as focused survey, to reinstate the license post suspension. Then we also do this under complaint survey, we call it as SRI. SRI stands for self-reported incident, meaning you are already aware about abuse and neglect at several places. So anytime there is an abuse incident that occurred, that facility or that entity is required to report to IDPH within 24 hours. So that comes to our hotline or through fax, and then we go and do a survey based on SRI. Again, it is the discretion of the division chief, field operation chief. They decide which to, if that entity has taken action towards that, they decide, the operations chief decide, yes, we can go and do that survey because there was an abuse that occurred, patient died, or somebody ill-treated a patient, then we make a decision to go and do that survey. So under state licensure programs, we have 15 different categories that we do survey on. Ambulatory surgical treatment center licensure survey, birthing center, that's new, that is a new addition to our surveys, birthing center licensure, children's community-based health centers, community-based residential rehabilitation center, freestanding emergency centers, home services licensure, home services placement licensure, home health licensure, home nursing licensure, home nursing placement licensure, hospice licensure, hospice resident survey, hospital licensure, post-surgical recovery care surveys, and subacute care survey. Now, you may be wondering, my goodness, we do plenty of, 14 different federal surveys, 15 different types of categories of licensure surveys. How do the surveyors get their knowledge and to do this type of surveys? There is a portal which is called as QSAP, Quality, Safety, and Education Portal, which is CMS regulated portal, where we all get a federal ID and we are obligated to go to this site and start learning about different kinds of survey. So that's called QSAP portal. We are also required to update our knowledge based on any changes to policies or regulations. So we go to a site where we go and look into all the policies and update our knowledge. So with regards to licensure surveys, we go to Illinois Administrative Code. For example, I have just shown here for hospitals, we go to Title 77, which is Public Health Part 250. So we go to this administrative code and look into the new rules and regulations if there are any changes. I just showed you a glimpse of it, okay? Now, we are also required as surveyors, as healthcare facilities and program surveyors, to look into the state operations manual. So you may be wondering, what is this SOM stand for? It's nothing but state operations manual. These are Medicare state operations manual with different appendix. So each appendix has different regulations that we need to go into, or the steps that we need to follow. For example, Appendix A is for hospitals. Appendix AA is for psychiatric hospital. Let's say I need to know more about rural health clinics, or you need to know about federally qualified healthcare clinics. We go into Appendix G. And we need to know about end-stage renal disease facilities. We go into Appendix H. And then let's say we want to know about critical access hospitals. we will go into Appendix W. So organ procurement, they go into Appendix Y. Emergency preparedness, we go into Appendix Z. And you might see if we want to learn or know more about immediate jeopardy, we go into Appendix Q, which gives the, the details about everything. So today, because of time constraints, I've been given just a few minutes to finish this. I will be slightly focusing on hospital COP. We call it as condition of participation. We look into Appendix A, and we look into the condition of participation of 42 CFR 482. CFR stands for Code of Federal Regulations. So Code of Federal Regulations for a hospital is under 42 CFR 482. And if you want to look into the state operations manual, it is under Appendix A. Now, hospitals are required to be in compliance with the federal requirements set forth by Medicare conditions of practice in order to receive the payment, right? So the goal of the hospital survey is to determine if the hospital is in compliance with the COP that is set forth in 42 CFR 482. Now, when you look at this, you can see there are so many COPs under hospitals. So there are approximately 23 COPs just for hospital survey. So like, I don't want to go line by line. You can see governing body, patient rights, medical staff, quality copy, medical records, nursing services. So you name it, all comes under a specific COP, which is nothing but condition of participation. And we also have one more. So 23 COPs plus the last one, which I want to point out, is EMTALA. That comes under hospitals. So discharge planning has a COP 482 CFR 482.43. So each COP governs different tasks that we need to look into. So with that being said, how do surveyors do their survey when we go into different entities like hospitals or dialysis? We follow this protocol, the 6 steps. We do offsite preparation, we do entrance, we do gathering of information, we do a decision making, and we do an exit, and then we do post-survey activities. Remember, we follow 3 techniques to collect the evidence: observation, document review, and interview. Those are the 3 techniques that we collect in order to proceed with our evidence collection and to proceed with to make a decision for decision making. So here, what I have shown is 42 CFR 482.12, which is regarding a governing body, where there should have a governing body for hospitals. And the next one is regarding patient rights. I would like to emphasize here that patient rights covers, this COP covers, this is huge. It covers a lot of standards, especially related to restraints, abuse and neglect, care in a safe environment, informed consent, HIPAA, all those comes under patient rights. All right. And condition of participation for medical staff. And this comes under 42 CFR 482.22. So where there must be a medical staff, they follow the bylaws and all of that. Okay. And then we have condition of participation for nursing services. There must be 24-hour nursing services, nursing staffing, all of that comes under that. So next, very interesting topic, immediate jeopardy. So before I go into immediate jeopardy, I just want to highlight that although surveyors go and collect evidence and submit it to Springfield field operations chiefs, section chiefs, the supervisors, they look into what the surveyors have done, and it goes through layers of review. And then the decision is made. It's not just that the surveyors go, do find everything, and then that's it, the end of the story. No, it goes through layers of review. They make the decision, and finally the decision will be sent out to the hospital or to the entity. Okay. So one of the findings could be an immediate jeopardy. What is immediate jeopardy? So immediate jeopardy represents a situation in which a non-compliance by providers, suppliers, anybody has placed the health and safety of the recipients at the care at risk for serious injury, serious harm, serious impairment, or death. That means there is an immediate jeopardy. So, due to time constraints, again, I just want to highlight the three components, key components of immediate jeopardy. One, non-compliance. Two, serious adverse outcome. Patient had a fall, or they did the wrong surgery, or they gave a wrong medication, and there was an adverse outcome. And that needs immediate action. So those are the three key components we look into. Maybe there was a fall for a patient. The patient fell from the bed and had a fracture, and nothing has been done yet. So these are the three components for immediate jeopardy. Now, when we as surveyors go to any entity and find an immediate jeopardy, we use a template. And this template has to be filled out by the surveyors. Whether was there a non-compliance, was there a serious injury, was there, did they do any immediate action? Let's say, for example, at a hospital. We fill this out, we submit it to the supervisor. The surveyor submit it to the supervisors, and it goes through layers of review until it goes to CMS. They will review it. There is a team that reviews it at the regional office for the state of Illinois. They review it and they say, yes, this is an immediate jeopardy. Go move forward and announce the immediate jeopardy at that hospital. So that's how. So it goes through layers of review. Everybody reviews what's going on, what went wrong, what was the immediate jeopardy for. Finally, there is what is called a statement of deficiency, which is nothing but CMS 2567, which will be issued to the entity regarding their non-compliance and with the standard level and condition level tags. So this is how the statement of deficiency looks, and they are required to submit a plan of correction. That was a glimpse of healthcare facilities and program surveillance. There's a lot more, but I just gave you a glimpse of it. And healthcare facilities have been working together, have been doing a lot of collaboration. We joined hands in collaborating with RIP, which is the Regional Infection Prevention Program. And we talk about hospital-acquired infections in the state of Illinois. And we have collaborated with IASCA. We have collaborated with IHA, where we talk about, we go to their conference and we present about the common citations. Same with IASCA, we go to Illinois Ambulatory Surgical Center Association, and we talk about the common citations, top 10 citations. So these organizations would like to know what are some of the common citations, and we talk about that at that conference, so they know what to do better, how they can improve. We talk about the immediate jeopardy. How much is it? We say the standard level citations were around 72%. Immediate jeopardies was very low. We want to keep those numbers really low. Condition level citations were around 25%. And we talk to them about Q tags. Let's say I'm talking with ASC, IASCA conference. We talk about this, we discuss about it, and we say what they could do to do better, to improve the quality of care. So these are the different Q tags that comes under Federal Ambulatory Surgical Center survey. And we also talk about the K tags. For example, when you look at this, the top 10 citations you can see: post-surgical assessment, or infection control program, or the form and content of the record. For example, when a patient is being discharged after a surgical surgery, there should be a physician order saying patient can be discharged, follow up within 3 days or 5 days to the clinic, whatever may be. And as surveyors, when we go there, we would like to see that. And if it isn't there, that's a citation. So these are some of the most common Q tag listings. K tags. K tags stand for life safety code. Those are some of the K tag listings that we can go through. I don't want to go step by step. Most common ones has been listed here. Now, Most importantly, I know Dr. Bonds wanted me to talk about the new ambulatory surgical treatment center rules and regulations that was effective since June 27, 2025, especially relating to interventional cardiac catheterization. So, with regard to cardiac catheterization, there was a new regs that was released. The any facility, any ambulatory surgical treatment center now can start doing cardiac catheterization provided they follow this. So it has to be approved by their consulting committee shall approve that, and then the facility shall only perform cardiac catheterization procedures approved for reimbursement by CMS. Okay, that includes PTCA. I hope you all know percutaneous transluminal coronary angioplasty, single or branched, and each additional branch of major coronary artery or a percutaneous transcatheter placement. So these are the listings that they could do, where they would be reimbursed by CMS. Now, in order to get the approval, they need to have the facility shall follow this clinical staffing. They must have a lab director. So this lab director who is board certified or board eligible in interventional cardiology, internal medicine, pediatrics, vascular surgery, or radiology with subspecialty training in cardiology or cardiovascular radiology. And they must have physicians who are board certified or board eligible in interventional cardiology. So if the facility provides PCI, percutaneous coronary interventions, physicians who perform PCI cardiac procedures in catheterization lab must meet the following criteria. So this is some good information that it's good for everybody to know. They should have completed at least 50 PCIs case sessions, have completed an interventional cardiology fellowship training program, be board certified, and have performed at least a total of 250 PCI sessions as an interventional cardiologist, and have a minimum 2 years experience at an attending level. Now, accreditation. So for their accreditation, they can go ahead and get accreditation. That CMS is fine with that. The cardiac catheterization lab shall be accredited by any nationally recognized accrediting organization. Like, for example, mostly what we see is Joint Commission. Their lab will be accredited by Joint Commission. They should also have a quality review and emergency transfer preparedness. For example, there should be peer review. The peer review shall develop a protocol of the services and its participation in a national registry. So what they do is the peer review team will evaluate the quality of studies related to morbidity and mortality of patients. How many deaths occurred? So they need to look into that. And they also should have a contract with the facility, with the hospital that is within 30 minutes radius by ground travel. And they should conduct mock drills, transfer drills, at least minimum of 2 times per year, and they should involve EMS crew while doing that. So as surveyors, when we go there, we should be able to see all of these, okay? So now, healthcare facilities and programs, we are planning to do some innovation to quality care. We are forming steering committees where we want to collaborate with clinicians like you, with physicians, and come up with innovative ideas to improve quality of care for the state of Illinois. So if you're willing to, let's spark innovation to quality care, please reach out to Dr. Barnes and let us know if you want to be part of the steering committee where we want to it takes a village to improve quality, right? Let's all join together and work together to improve quality of care for the state of Illinois. That ends my presentation. Thank you very much.
Okay, thank you, Somi. So let me just pull my screen up here, and I started with the long-term care survey process. Give me 1 minute to get this all set up. All right. All right. So, like I said, thank you again, Somi. My name's Jonathan Harwood. I am the acting bureau chief for long-term care, and I am going to take us through, similar to what Somi discussed, I'm going to talk about the long-term care side of the regulatory process. So here are our objectives. So we'll go through the skilled nursing facility survey process. Okay. So, just a brief introduction. So, the Department of Public Health does survey those long-term care facilities to ensure that they are compliant with CMS federal regulations. This was derived under the Social Security Act of 1819, which CMS did require that any certified facility undergo an annual certification survey to ensure that they were compliant with the federal regulations. Within that act, under the section 1864, that directs that the Secretary of Health and Human Services will enter into an agreement with the state agency for that state agency to provide that oversight and enforcement and certify those long-term care providers, which is how the Department of Public Health um, does survey then on behalf of the federal CMS. In addition to surveying for compliance with the federal regulations, the state agency does survey for the regulatory compliance with the state licensure regulations as well. And as Somi had stated, they are located within the Illinois Administrative Code, Section 77, Part 300 for the nursing homes. Those Illinois administrative codes are primarily developed from the Nursing Home Care Act, which authorizes the department to license and regulate those long-term care facilities. The purpose of the survey process is to ensure that facilities are providing the appropriate quality of care to residents and ensure that overall patient safety. Okay, so here's just a list of the types of surveys that we do. We'll talk about each of these in the next few slides. The standard survey is just that annual survey. The extended survey may be done if there is findings of substandard quality of care or higher level harm level type deficiencies. We'll talk a little bit about the complaint incident surveys and then the revisit surveys that do occur following identified noncompliance. So the standard annual health survey, CMS does direct that the annual standard certification surveys are conducted no later than 15 months after the last day of the previous standard survey, and that the statewide average interval between the standard surveys of the nursing homes not exceed 12 months. So this typically provides a 9 to 15 months type of a window or interval period in which that standard annual certification survey could be conducted. All the surveys that are conducted uh, by IDPH are unannounced. So this helps the department to gather accurate observations of operations and overall quality of care that is being provided. As the state agency, the IDPH Office of Healthcare Regulation team is tasked with conducting those CMS certification surveys on behalf of CMS. CMS does provide the protocols, the long-term care procedure guides, and the critical element pathways as guidelines and resources for surveyors when they are conducting their annual standard surveys. So here are a few focus areas for the annual survey. This list is not all inclusive, but it includes overall high-level overviews of some of the topics or focus areas that the survey teams do focus on. Quality of care is a big one. Resident rights, quality of life, nursing services, including adequate and sufficient nursing staff, infection prevention control. There are some aspects looking at the dietary needs, nutrition services, pharmaceutical services, ensuring accurate dispensing of medications, abuse, neglect, and theft, and then overall care planning and generalized plan of care. So some of the methods that are associated within the annual survey process consists of conducting are completing a facility tour to observe the resident interactions with other residents, interactions with staff, and the overall quality of care that is being provided. The survey team will often conduct interviews with residents or staff to gather additional information or clarify information that was observed or reviewed in a record. And as Somi, I think had stated too, there is the component of the record review. So the survey team will review various records throughout the survey, including resident medical records, care plans, resident assessments, progress notes, and any facility policies or procedures. The team also does review the facility's quality assurance and performance improvement program and compares that to some of the issues or concerns that are identified throughout the survey to ensure that the facility is incorporating that into their quality assurance program. So as far as the complaint process, complaints can be submitted anytime to the department, and they can be submitted by residents, families, staff, client advocates, or any members of the public. So the department also receives complaints from other state agencies that are involved in care or oversight or advocacy of nursing home residents. They are submitted and received by the department via telephone, fax, email, or through our authenticated public portal. The complaints are typically, they are received and input into our state and federal database in our central complaint registry. The central complaint registry is responsible for taking those phone calls, receiving the emails, or the complaints that are submitted via the portal, and then inputting those in assigning the appropriate triage level into our state and our federal database. Based on the severity of the complaint or the allegations that are submitted, that determines the triage priority level, which determines the time frame for the on-site investigation. State and federal guidelines do direct that facilities shall report certain incidents to the department. So the facilities can submit the incident information to the department via telephone, fax, email, or again through that authenticated portal. Any incident involving abuse, neglect, theft, exploitation, or mistreatment of residents, including injuries of unknown origin, are reported immediately, but not greater than 2 hours after the allegation is made. If the event that causes that is found that is caused by, causes serious bodily injury or harm. Or it's reported within 24 hours if it does not cause any type of bodily injury or harm. Then within 5 working days after the final results then should be submitted to the department for review. The facility is required to notify the department if there's any serious incident or accident. The state administrative code defines serious as any incident or accident that causes physical harm or injury to a resident. So the facility is required to notify the regional office within 24 hours after that reportable incident and then send a narrative summary within 7 days. So complaints and incident investigations are prioritized utilizing the same triage criteria. There are some differences that do exist between the state and federal triage guidelines, requiring the state agency to apply the more stringent standards. So the state operations manual defines an immediate jeopardy as a situation in which the provider's noncompliance with one or more requirements of participation is caused or is likely to cause serious injury, harm, impairment, or death to the resident. So the intakes are assigned this level if the alleged noncompliance indicates that there was some type of serious injury, harm, impairment, or death, or if there is a likelihood for such. Examples of an IJ or immediate jeopardy prioritization could include allegations regarding resident abuse, when it's uncertain if there's adequate protection for the resident or other residents involved, um, or an emergent situation such as some type of fire which resulted in an evacuation. The federal guidelines do direct that the state agency initiate an on-site within 3 business days of receipt after an immediate jeopardy complaint or incident investigation is submitted. However, the Illinois Nursing Home Care Act directs that the department will investigate all complaints um, regarding or with concerns to resident life or safety within 24 hours. So um, on the state side of things, if we triage something as an immediate jeopardy, we would need to go in within 24 hours. So that's where there's a little bit of that difference between the state criteria and the federal criteria. Intakes are assigned as that non-immediate jeopardy high if the alleged non-compliance with one or more requirements may have caused harm that negatively impacts the individual's mental, physical, and/or psychosocial status, and are of such a consequence to the person's well-being that a rapid response by the department is indicated. Those are required to be investigated according to federal guidelines within 15 business days of the receipt, but not to exceed 18 days. All right. So the complaint or the incident investigation surveys utilize more of a focused scope and review during the investigation. So the process directs that the team focus on the specific allegation or allegations that were reported on the intake report. So depending on the information gathered during the focused investigations or during the interviews, the team may need to expand the investigation to other pertinent or applicable areas. The team will attempt to interview the individual who is the subject of the complaint or the incident to gather additional information. The team will also conduct interviews with other residents, family, resident representatives, or key staff members who may have been witness to the situation or allegation at hand. As part of any routine survey or complaint survey, the team will conduct observations of care, noting interactions between residents to residents or staff to residents as well. And they will also conduct focused record review, such as policies, procedures, or incident report investigations. Upon completion, the surveyor will determine if the facility is in compliance with the state and federal regulations. And if they are not in compliance, then the regulatory deficiency will be cited. The facility may be issued a federal deficiency and assigned appropriate scope and severity. This is often based on the number of residents or persons affected or impacted, which could be isolated to one person, a pattern, of typically 4 to 5, or a widespread issue. Um, let's see here. Okay. So once the provider has received their statement of deficiencies, they may be required to submit an acceptable plan of correction to the department. The department has procedures to ensure that a revisit survey then is conducted to verify the facility is back in compliance. So an on-site revisit would be required if the original survey that resulted in noncompliance um, was any type of substandard quality of care, harm, or immediate jeopardy. Other surveys that resulted in less severe noncompliance may have the ability to have an off-site revisit conducted. So as I previously indicated, all skilled nursing facilities are required to be licensed by the department. So if the provider is a new establishment, they shall submit an application for licensure to the department for approval. They'll be issued a probationary license, which is valid for 120 days. Within 30 days of the expiration of the probationary license, the department will conduct an on-site probationary licensure visit to ensure the facility is in compliance with the state administrative codes. Other examples for licensure type facilities would include any type of change of ownership facility or any construction projects which may have resulted in bed level changes, additions, or removal of beds. Here are the frequently cited deficiencies. These are the federal deficiencies within long-term care homes. So I won't go into each detail. I could spend an entire hour just talking through the deficiencies, but for time's sake, I'm just posting these up here. These can all be found in that state operations manual at Appendix PP if you'd like to further review. And here are just some of the resources, and I think I'm going to stop sharing because I think we're going to put all of them at the end, but I will turn it back over to Dr. Barnes. See if I can stop sharing.
All right, thank you, Jonathan. And I am just going to go up to the resources slides. We just sort of merged some of the resources here. I'll just go back. So in addition, there are resources that have been embedded in live links throughout. So it'll take us a couple of days to get communications clearance. And then when we send the slides out, you should have the live embedded links for all of these. In the interest of time, I want to make sure we get to questions if they need it. I'm just going to hover over this slide for a minute. David, if you can also put the link to, I don't know if there's a way to put the link in the Q&A section. There's a live link, but you can also click on this. And of course, when you get the slide deck, this will be on there. So if you can take a picture of the QR code, you get your 1 hour CME credit by, and of course, certificate of participation.
I'm sorry, I will also be emailing all participants this link as well. So
Perfect.
to their email.
Okay. All right. With that, since everyone will get an email with the link too, I am going to stop sharing and open it up for questions so I can see if there are any additional questions. One was, yes, the session is being recorded and will be sent out, the recorded session, to all those via email to their registrants. Can you post the link again? All right, I'm gonna paste it as an answer to that question. Oh, sorry. And then I think everyone should be able to see it. Apologies, this is taking a little longer. Okay, I think there's another question on, give me a second here. Just make sure I can paste it to the right question. Okay. All right, so the link is now in the Q&A. Definition of serious injury. Is it no longer requiring suture staples or fractures? I don't know if the definition of serious injury has changed, but there's a national quality NQF. They first came up with an original definition of serious reportable events in around 2003, 2004. They updated it again in 2011, and the most recent update was in 2025. So that, I think you can, the link to that most recent update of the 23, 28 SREs is on there. I'm not sure if that answers your question, but again, we're not necessarily, I think if there's an issue of harm, I don't think the mechanism really matters as much, or whether it's a suture or stable. If it's, I think the end outcome of the harm and the degree of responsibility of the healthcare practitioner, as well as the oversight of the system in contributing to that harm. Any other questions? No, we have only 1 minute left. So one last question if anyone has them. And we hope this was helpful and useful to those who attended, and happy to share more resources. If people have ideas on future topics, we are here. Next time we'll put a new fresh survey on ideas for future topics. And we have a pretty big lineup already, but we'll be happy to make sure that we address those. So with that, I know it's 1 o'clock. So thank you everyone for joining us, and we'll see you next month. Take care. Bye.